She has no relevant financial relationships with commercial interests, nor discusses unlabeled or unapproved uses of drugs or devices during this presentation. Dr. Soto-Rosario?
Thank you for the introduction, Jared. Good afternoon, everyone. Today we will be discussing the pharmacotherapy of HIV. I am excited to be here with you today, presenting on this ever-changing topic. In order to ensure that all aspects of HIV antiretrovirals are discussed in adequate detail, as was mentioned, this topic will be subdivided into 3 webinars. Over the course of the lectures, participants will be able to state the goals of antiretroviral therapy, identify antiretroviral drug classes and describe their mechanisms of action, discuss the initial therapy considerations, and list 5 common and significant drug interactions. In the era of highly active antiretroviral therapy, our treatment goals are very different from what they were many years ago. Current ARV regimens are potent combinations. Therefore, the goals of ART include to reduce HIV-associated morbidity and prolong the duration and quality of survival, to restore and preserve immunologic function, maximally and durably suppress HIV viral load, and finally, to prevent HIV transmission. It is often said in the HIV community that treatment is prevention, because by maximally addressing and suppressing a patient's virus, you are reducing the likelihood that he or she will transmit the virus to another individual. Therefore, the final goal is to prevent transmission. Keep in mind, however, that although the risk of transmission may be greatly decreased by achieving undetectable viral loads, HIV may still be present in secretions, and the risk of transmitting HIV is not eliminated altogether. In order to achieve these treatment goals, several factors must be taken into consideration. When selecting the initial combination regimen, there are several preferred and alternative ARV regimen options that are recommended for use and will be discussed in a future presentation. Many have comparable efficacy, but vary in dosing frequency, pill burden, drug interactions, and side effect profiles. Drug-resistant tests must be done in all patients prior to initiating therapy. In a treatment-naive patient that is just coming to care, there is a 6 to 16% chance that this patient has been infected with a drug-resistant strain of HIV. This means that having never taken a single medication for HIV, the patient may already be resistant to certain ARVs. Improving adherence is of utmost importance. Suboptimal adherence can lead to reduced treatment response, virologic failure, and drug resistance. Incomplete adherence can result from complicated regimens, patient factors such as active substance abuse and depression, and health system issues, such as lack of insurance coverage or inadequate education and support. A regimen should be tailored to each patient to enhance the adherence and to improve long-term treatment success. Individual regimen choice is based on such considerations as expected side effects, convenience, comorbidities, interactions with concomitant medications, and the results of the pre-treatment drug resistance test. Before beginning our discussion on the antiretroviral drug classes, let's go over the life cycle of HIV. In order to fully appreciate how the medications work, it is helpful to understand the natural progression and replication of HIV. First, the virus must enter its host cell by binding and fusion. HIV binds to a CD4 receptor and one of 2 co-receptors on the surface of a CD4 lymphocyte, either CCR5 or CXCR4. The virus then fuses with the host cell, and after fusion, the virus releases RNA into the host lymphocyte. Reverse transcriptase is the enzyme that converts single strand of RNA of the virus into double-stranded HIV DNA. The new HIV DNA must then be integrated into the host's cell nucleus via an enzyme called integrase, which incorporates the viral DNA into the host's own DNA. This integrated HIV DNA is called provirus, which can remain dormant for years. Once the host cell is activated, the provirus creates messenger RNA to then make long chains of HIV proteins. The assembly of the long chains begins to take place, and the enzyme protease will actually cleave the protein chains into individual proteins. It cleaves the long protein strands into individual proteins, which then these proteins go on to combine with RNA genetic material, which enables the virus to assemble. The new virus then buds from the host cell, and the protease enzyme continues to cleave the final proteins so that then it can become a functional and mature virus. Now that we have discussed how HIV replicates, we can see what stages of the HIV replication cycle are targeted by current ARVs. Current drug targets include HIV virus binding to the CD4 cell, fusion with the host cell. Two different drug classes target the reverse transcription process, integration into the virus complex, into the HIV DNA integrating into the host cell DNA, and there's also a drug class that targets the protease enzyme, thus preventing protein cleavage. One other drug target that is currently being investigated is the maturation step, so-called maturation inhibitors. There are currently 6 different classes of antiretroviral drugs that are available. They are the nucleoside reverse transcriptase inhibitors, or NRTIs, the non-nucleoside reverse transcriptase inhibitors, NNRTIs, the protease inhibitors, also called the PIs, the integrase strand transfer inhibitor, also called the integrase inhibitor. Then there's also the fusion inhibitor and the CCR5 antagonist. There are 24 different antiretroviral medications available. In order to facilitate this discussion, we will discuss each drug class, describe their unique characteristics and class effects, then list details regarding the medications with regards to drug interactions, dosing, and special considerations. During this first webinar, we will be focusing on the class of the NRTIs. The NRTI class of medications targets the reverse transcription process. As you recall from the previous slide, the reverse transcriptase enzyme is responsible for transcribing single-stranded viral RNA into double-stranded DNA. NRTIs inhibit this viral enzyme. These medications must first undergo intracellular phosphorylation to be active. They mimic the natural substrates that are normally incorporated into this DNA strand. The subsequent incorporation of these medications into the viral DNA strand results in chain termination, halting the virion production. When discussing some of the details of this drug class, it is important to know that they primarily undergo renal excretion, with the exception of 2 medications. Abacavir, which is metabolized by alcohol dehydrogenase, and Zidovudine, which undergoes glucuronidation. An important consideration when dosing these medications is therefore that you have to adjust their renal function, and you need to estimate their renal function in order to dose these medications appropriately. If you have computer software that automatically calculates a patient's creatinine clearance, it is important to verify which weight it is using to estimate a patient's renal function. If a patient's weight is close to their ideal body weight, their creatinine clearance is adequately estimated. If, however, a patient is obese and this weight is utilized to estimate their creatinine clearance, their renal function will be overestimated and their medication doses may not be appropriately adjusted. In these cases, you may consider using their adjusted body weight in the Cockcroft-Gault equation when you're estimating their renal function. Continuing with regards to the medications and their metabolism, it is important to know that these medications do not undergo metabolism by the cytochrome P450 system. Therefore, drug interactions related to this metabolic pathway are not a concern for this drug class. As far as administration is concerned, the majority of these medications can be taken without regards to meal. There is one exception to the rule, however. Didanosine must be taken on an empty stomach. There is only one time when actually didanosine can even be taken without regards to meals, and this is when it is co-administered with tenofovir. However, it is important to also remember and to know that tenofovir and didanosine is not a combination that is currently recommended as initial therapy. The NRTIs currently available as single-entity products are abacavir, also known as Ziagen, didanosine, brand name Videx, Emtricitabine, brand name Entriva, Lamivudine, which is also called Epivir, StaviD, known as Verit, tenofovir, brand name is Viriad, and Zidovudine, also called Retrovir. As we discuss each drug individually, you will notice that each drug also has its own three-letter abbreviation. Learning the brand, generic, and abbreviations for all the medications may seem daunting, but I hope that by the end of this presentation you will become more comfortable with each of these medications. In addition to the single drug entities shown in the previous slide, there are also multiple co-formulated products. These fixed-dose combination products offer added convenience and reduced pill burden for patients on antiretrovirals. Now we will move on to discussing the individual medications. Abacavir, also known as ABC or Ziagen, is a guanosine analog, which means that it is structurally similar to guanosine, and when it incorporates itself into the viral DNA, it is mistaken for guanosine. The recommended adult dose is 300 milligrams twice daily or 600 milligrams once daily. Remember that the majority of NRTIs are renally eliminated, with abacavir being one of the exceptions. Because it is hepatically eliminated, dose adjustments are required in patients with mild hepatic dysfunction described as having a Child-Pugh score of 5 to 6. For these patients, a reduced dose of 200 milligrams twice daily is recommended. In patients with a Child-Pugh score greater than 6, this medication is contraindicated. An important clinical pearl to remember when considering abacavir therapy is that screening for HLE B5701 must be done prior to initiating therapy. When we discuss adverse effects associated with these medications, we will discuss the signs and symptoms of the abacavir hypersensitivity, which are important to recognize as this can be a life-threatening reaction. This further emphasizes the importance of screening for this allele. If a patient is positive for HLA B5701, abacavir should not be started. Didanosine, also known as DDI or Videx, is a nucleoside analog of guanosine. This medication's dosing is weight-based. If a patient is greater than or equal to 60 kilograms in weight, the recommended dose is 400 milligrams daily. If it is co-administered with tenofovir, another NRTI, the dose is reduced to 250 milligrams daily. This is because tenofovir increases the levels of didanosine in vivo, therefore the dose adjustment is warranted. If the patient weighs less than 60 kilograms, the recommended dose is 250 milligrams, with a reduced dose of 200 milligrams if it is co-administered with tenofovir. It is important to take this medication a half hour before or 2 hours after a meal. Because this medication is renally eliminated, a reduced dose is recommended for patients with a creatinine clearance less than 60 milliliters per minute. The renal dose adjustments can be challenging to memorize as the dosing is based on the patient's weight and renal function. If a patient has creatinine clearance between 30 and 59 and weighs more than 60 kilograms, the recommended dose is 200 milligrams daily of didanosine. If the person weighs less than 60 kilograms, the dose would be 125 milligrams daily. In patients on hemodialysis or continuous ambulatory peritoneal dialysis, please note that it is important to advise that patients take this medication after a dialysis session, not before. In practice, I'd also like to comment that when determining a dose for a patient with renal insufficiency, it is best to refer to the dosing guidelines to ensure that an appropriate dose is selected. One helpful reference are the pocket cards, such as those provided by the Florida Caribbean and AIDS Education Training Center. The link to that is available on the website. Emtricitabine, also known as FTC or Emtriva, is a nucleoside analog of cytosine. The recommended dose of this medication depends on which dosage form is utilized. The capsules come in a 200 milligram strength, and the adult dose for the capsule is 200 milligrams daily. If considering the oral solution, the recommended dose is 240 milligrams daily. Like didanosine, this medication is also renally eliminated and requires dose adjustment for patients with a creatinine clearance below 50. In addition, it is important to counsel dialysis patients that they are to take this medication after their hemodialysis session on these days. An interesting fact about this medication is that it is not only active against HIV, but that it is also active against hepatitis B. This is an important factor to consider because if a patient is HIV positive, co-infected with hepatitis B, abrupt discontinuation of emtricitabine can lead to adverse outcomes. If this medication is abruptly discontinued in these patients, severe acute exacerbations of hepatitis can occur. As we just mentioned, this medication requires dose adjustments in patients with a creatinine clearance below 50. Unlike didanosine, whose doses in renally compromised patients result in lower daily doses, adjustments of emtricitabine for renal impairment are achieved by prolonging the dose interval or decreasing the daily dose. An additional challenge to consider is which dosage form the patient is taking, as recommended doses differ based on whether the patient is taking capsule or solution formula. For example, if you have a patient with an estimated creatinine clearance of 20, they will fall within this category. They will need to take 200 milligrams every 72 hours of the capsule, or if they are taking the solution, they can take 80 milligrams daily. For this medication, it is also recommended to give the doses after hemodialysis on dialysis days. These slides with the dose adjustments can also be used for future reference, and I would recommend referring to this or the pocket cards when you are dosing your patients with renal impairment. Lamivudine, or 3-TC, brand name Epivir, is a nucleoside analog of cytosine. It is very important to note that due to the similar activity, lamivudine and emtricitabine should never be given in combination. The recommended adult dose for lamivudine is 150 milligrams twice daily or 300 milligrams once daily. Because it is also renally eliminated, it requires dose adjustments in patients with renal insufficiency, particularly those with a creatinine clearance below 50. Like emtricitabine, it is not only active against HIV, but it is also active against hepatitis B. If a patient is HIV positive co-infected with hepatitis B, currently taking lamivudine, abrupt discontinuation can lead to adverse outcomes. If therapy is discontinued, severe acute exacerbations of hepatitis can occur. The renal dose adjustments for lamivudine are more straightforward than the other medications we have discussed. Once a patient's creatinine clearance is below 50, once a patient's creatinine clearance is below 30, a one-time loading dose of this medication is given, followed by a lower maintenance dose. Please note that the frequency of the medication does not change despite worsening renal function. The patient will still take this medication daily. Even if a patient is on hemodialysis or with a creatinine clearance below 5, the dose will still be given daily. And as with all the other medications we've discussed, If a patient is on dialysis, it is recommended that they take this medication after their dialysis session. StaviD, or D4T, brand name Zerit, is a nucleoside analog of thymidine. Like didanosine, StaviD has weight-based dosing recommendations, also with a cutoff of 60 kilograms. So if somebody weighs 60 kilograms or more, the recommended dose according to the package labeling is 40 milligrams twice daily. If someone weighs less than 60 kilograms, the dose is 30 milligrams twice daily. Interestingly, the World Health Organization recommends 30 milligrams twice daily, regardless of body weight. The WHO recommendation is based on a systematic review of 9 randomized trials and 6 observational cohort studies, which strongly suggest that StaviD-containing regimens maintain clinical and virologic efficacy when dosed at 30 milligrams twice daily, regardless of body weight. The reduced dose is associated with lower toxicity, particularly the decreased mitochondrial toxicity, especially peripheral neuropathy. Limited data is available to show the decreased incidence of lactic acidosis. The WHO has even evaluated the use of lower doses than 30 milligrams twice daily. However, data has not supported this and it is still under review. Please note that the DHHS guidelines do recommend the same doses as listed on the package insert of this medication, which is the weight-based dosing we have described. Renal dose adjustments for StaviD are based on a patient's weight. For example, if you have a 70-kilogram patient with a creatinine clearance of 35, the recommended dose is 20 milligrams twice daily. If this same patient weighed 55 kilograms, the recommended dose would be 15 milligrams twice daily. Tenofovir, also known as TDF or Viriad, is the nucleotide analog of adenosine. This is the only nucleotide analog available, and while this is important with regards to a chemical perspective, when it comes to prescribing these medications, there is no therapeutic superiority of having a nucleoside versus nucleotide for these medications. The usual adult dose is 300 milligrams daily. Like most of the NRTIs already discussed, it requires dose adjustment in patients with renal insufficiency with creatinine clearance below 50. Like Lamivudine and Emtrione, tenofovir is not only active against HIV, but it is also active against hepatitis B. If a patient with hepatitis B is being treated with tenofovir and they are also HIV positive, abrupt discontinuation of tenofovir can lead to adverse outcomes, such as the severe acute exacerbations of the hepatitis. Like the dose adjustments for the Emtrione capsules, the dose adjustments for tenofovir adjust the dosing frequency instead of the medication dose. For example, if a patient has a creatinine clearance of 20, the recommended tenofovir dose is 300 milligrams twice daily. If a patient is on hemodialysis, he or she will take this medication only once a week, and it is recommended to give the dose after hemodialysis on the dialysis day. While the medication dose adjustments may be easier to remember for this medication, it is important to be aware that as practitioners, it can be challenging to ask our patients to take a medication every other day or twice a week while expecting 100% adherence. Especially in these cases, it is important to address adherence concerns and provide the patient with adherence tools to ensure that they do not miss doses. And now we come to the final NRTI medication of this presentation, which was the first medication to be approved for HIV in 1987. Zidovudine, also known as AZT or ZDV, and by the brand name of Retrovir, is a nucleoside analog of thymidine. Like the recommended adult dose of this medication is 300 milligrams twice daily or 200 milligrams twice daily. The recommended adult dose of this medication is 300 milligrams twice daily or 200 milligrams 3 times daily. Like the majority of NRTIs discussed, Zidovudine requires dose adjustment in patients with renal insufficiency. However, the adjustments are not warranted until a patient's estimated creatinine clearance is below 15. At this point, 100 milligrams 3 times daily or 300 milligrams once daily can be given. An interesting piece of information about this medication is that it is available in multiple dosage forms, being tablet, capsules, oral liquid, and intravenous formulations. And this was actually the first medication to be used to prevent mother-to-child transmission during labor and delivery. And now, before we go further, let's answer a quick question. Which of the following medications require dose adjustment in a patient with creatinine clearance of 45 milliliters per minute? I would like to ask if you can please answer and provide your answers via the chat session that's located on the right-hand side of your screen. Okay, I don't seem to see any answers, but that are popping up here. But let's go over the drugs one by one to describe if they would qualify to warrant a dose adjustment of creatinine clearance below 45 or below. Tenofovir is a medication that requires renal dose adjustment, and this is one of the answers because it requires dose adjustment in patients with a creatinine clearance below 50. Didanosine requires adjustment in creatinine clearance less than 60, so this would also be an answer. And the other answer would be Lamivudine, which also warrants a dose adjustment in patients with a creatinine clearance of 50 or below. Abacavir, if you remember, is not hepatically eliminated. It is hepatically eliminated, so it does not warrant renal dose adjustments. And Zidovudine, the final medication, only requires dose adjustment in patients with a creatinine clearance of 15 or below. Moving on to adverse effects. The NRTI class is associated with certain adverse effects. In addition, specific medications also have unique side effects that are important to consider. All NRTIs can cause lactic acidosis with hepatic steatosis. Although all NRTIs could potentially cause these problems, the incidence is higher with D4T, also known as StaviD, DDI, or Didanosine, and ZDV, or Zidovudine, and lower with the other NRTIs in this class. Lipodystrophy is another class effect. This is a collection of body shape changes in people taking ARVs. They can include fat loss in the extremities, fat deposits in the stomach, back of the neck, and breasts in both men and women, and metabolic changes. There is a higher incidence of lipodystrophy with StaviD, although it can occur with any NRTI. Moving on to the unique side effects for each of the NRTIs. Abacavir, or ABC, can cause a hypersensitivity reaction, which was previously mentioned. Rash can also occur, and there is a possible increased risk of MI in patients taking this medication. The literature is inconclusive on whether or not there is a true risk, as conflicting results have been shown in the literature. Didanosine, or DDI, can cause gastrointestinal side effects, peripheral neuropathy, pancreatitis, and possible non-cirrhotic portal hypertension and an increased risk of MI. Again, I emphasize that in any patient that you are considering abacavir, or ABC, a screening for the HLA-B5701 should be performed. StaviD, or D4T, is associated with peripheral neuropathy, lipoatrophy, and pancreatitis. The adverse effects associated with this medication are related to mitochondrial toxicity. As you will recall, it is because of these toxicities that the WHO recommends lower doses. Tenofovir, or TDF, can actually cause renal impairment and in some cases can cause Fanconi syndrome. If you recall, it was mentioned that this medication also requires renal dose adjustment in patients with renal insufficiency. Therefore, it is important to monitor a patient for renal impairment that may be secondary to tenofovir treatment. This medication can also cause a decrease in bone mineral density and osteomalacia. Headaches and GI intolerance are also common adverse effects. Zidovudine, or StaviD, better known as AZT, can cause headaches, GI intolerance, lipoatrophy, and bone marrow suppression. This is an important side effect to be aware of, especially in patients who may be on concurrent therapy that can cause bone marrow suppression. As we have mentioned numerous times in this presentation, hypersensitivity reactions can occur in patients receiving abacavir therapy. And while it does not occur in every single patient that receives abacavir, it is a clinically significant presentation, and it's an important thing to consider and to always remember in a patient who is on this medication. If the patient is screened for the HLA-B5701 and the allele result shows that it's positive, you should never initiate abacavir therapy. For patients who are negative for this allele and are started on abacavir, the hypersensitivity can still occur. 90% of all hypersensitivity reactions occur within the first 6 weeks of therapy, with a median onset of 9 days. Symptoms associated with this reaction are nonspecific, including the following that I have listed here for your reference, and this is listed in order of decreasing frequency. Patients presenting with these symptoms may be mistakenly identified as having a viral illness. However, the patient who is having a hypersensitivity reaction typically experiences worsening of the symptoms with continuation of abacavir therapy. And it is important to also know that a patient with a hypersensitivity reaction to abacavir should never be rechallenged with the medication. As was mentioned in a previous slide, lactic acidosis with hepatic steatosis is a possible yet rare complication of NRTI therapy. The signs and symptoms of lactic acidosis can include abdominal distension, nausea, vomiting, diarrhea, dyspnea, and patients may experience some generalized weakness. Though this complication can happen in any patient on NRTI therapy, it is more likely to occur in patients who are taking StaviD and Didanosine during pregnancy, in patients who are female, those who are obese, and in patients who have been on prolonged therapy with NRTIs. Drug interactions for this class are not as extensive as those that can occur with other antiretroviral drug classes. Because these medications are primarily renally excreted, the cytochrome-mediated interactions are not a concern. If another drug that affects renal elimination is administered, there are potential drug interactions that can come up. An important interaction to note within the NRTI class is between abacavir and alcohol. Because ABC is metabolized by alcohol dehydrogenase, it is important to advise patients to avoid alcohol consumption. And now that we have all discussed the NRTI drug class and you're experts in this drug class, I would like for you to use the chat feature that is available through this webinar to answer this question. In an HIV patient co-infected with hepatitis B, which medications, when discontinued abruptly, can cause severe acute exacerbation of hepatitis? Okay, the answers that we are looking for is that there are 3 medications within this drug class which are active against hepatitis B and HIV. These are Lamivudine, Emtrione, and tenofovir. This is the conclusion of the first part of the antiretroviral discussion. In the next webinar, we will be discussing the mechanism of action, dosing, clinical considerations, and drug interactions for additional antiretroviral drug classes. Thank you for your time, and I will be happy to answer any questions you may have at the moment.
Thank you very much, Dr. Soto-Rosario. At this time, we are unmuting all phone lines for questions. If you want to ask a question, please click the raised hand button so that we may call on you, or use the chat feature to type your question. All chat questions will be read aloud to participants. If there are no questions, I want to thank you all for participating in today's webinar. As usual, a recording will be made available on the Virtual Learning Lab's Building the Foundation page. While there, we invite you to post follow-up questions in the ARV forum. Also, the answers to the evaluation questions, which you will get after you close out of this webinar, will be posted in this forum. Additionally, you can reach Dr. Soto Rosario or any member of the AETC NCHCMC staff by emailing us at clinical@nchcmc.org.